It's not going to be the first slide. There we go.
Good afternoon, everyone. I'm Bob Braddock, one of the Transformative Technologies class organizers. And it's my pleasure to welcome you to our 6th class. Today, we're tackling the topic of health tech, the impact. It's the impact of healthcare applications on healthcare. In this session, we'll focus on patient and provider health tech applications across a number of domains. First, we'll set the stage with a framework for discussing how innovations are developed and adopted in the context of our US healthcare system. And then we'll turn to key emergent technologies, their applications, and their impact on healthcare delivery, including a focus on our healthcare ecosystem right here in the Berkshires. It's my distinct privilege to introduce our moderator, Gordon Josephson. Dr. Josephson, MD, MPH, practiced as an emergency physician from 1977 through 1997. That was 77 through 97. And then from 97 to 2015 as Chief Operating Officer of Baystate Medical Practices as Chief Operating Officer, involving a practice of 600 physicians and advanced practice clinicians affiliated with Baystate Health in Springfield, Massachusetts. His Master's of Public Health is from Harvard, and Gordon is an OLLI board member, serves as Vice President of the board, and chairs its governance committee. Gordon, over to you.
Thank you so much, Bob, for your kind and introductory remarks. I would also like to welcome all of you to the 6th session on transformational technologies. Of course, this one, as Bob mentioned, will focus on healthcare. So as a quick housekeeping matter, and I'm sure this is familiar to many of you, as with previous transformational technology sessions, this presentation is going to be presented in the webinar format. That means that you'll be able to see and hear our keynote speaker and panelists, but we won't be able to see you or hear you. Of course, at the conclusion of formal remarks and discussion between our keynote speaker and panelists, there'll be ample time for your input and inquiries by way of the chat feature, which I'm sure you're familiar with. Further, you'll be able, we can enable your audio as needed. So if there's a particular piece of chat that for which it needs to be supplemented with your voice, we can do that. So without wasting any time, let me get started. And first, I'd like to introduce our keynote speaker, who is on our, I believe you're seeing now, Dr. Michael Miller. A resident of Williamstown, Dr. Miller is a healthcare and life science policy and subject matter expert, supporting organizations to improve their programs and innovations. For more than 30 years, he has been planning, developing, and directing projects that expand affordability, access to care, and improve clinical and economic outcomes. He has worked with large corporations, companies, government organizations, entrepreneurs, and Lever, the business accelerator in North Adams, Mass. Dr. Miller received his undergraduate degree from Williams College and his MD at the Yale University School of Medicine. His clinical experience includes surgical training at the University of Vermont and medical care at free clinics in the Washington, D.C. area. Please allow me to welcome Dr. Miller, and I think you can see his image on our screen. Let me also introduce our panelists to you. First is Joe Diver. He is the Director of Digital Transformation at Baystate Health and TechSpring in Springfield, Mass., as well as an IT consultant with Eagle Consulting. Joe brings professional expertise and experience and credentials in digital healthcare innovation strategies, partnering with senior executives to align their business and technical strategies. A graduate of Suffolk University, Joe has served in a variety of healthcare leadership roles, including 2 stints as a healthcare chief information officer and vice president of Patient Keeper, an innovative electronic health record platform. Next, and by no means least, Dr. Sprowl is a family physician with significant clinical experience practicing in the Boulder, Colorado area. He has expansive management experience in management and physician executives roles with Centura Healthcare in Colorado, Peace Health in Washington State, and Maine Medical Center, and Maine Health in Portland, Maine, and most recently with SSM Health in Wisconsin. He has an extensive experience with the selection and implementation of electronic health records, population health management, and clinical integration. Chris holds an undergraduate degree in biochemistry from SUNY Buffalo, master's degrees in biophysics and medical management from the University of Minnesota and the University of Southern California, respectively, and his medical degree is from SUNY Buffalo. Right now, Dr. Sprowl is the interim medical director for Community Health Plan here in the Berkshires. And last, not least though, William Young, who is the Chief Information Officer with Berkshire Health Systems. Bill is a seasoned IT healthcare executive, serving initially in Ellis Hospital as its Chief Information Officer in Schenectady, and then beginning in 2003, and later in a similar role with Berkshire Health Systems beginning in 2009. In each case, managing multi-million-dollar information system platforms, notably at Berkshire, an institution-wide electronic health record system incorporating data from hospitals, physician practices, laboratory, radiology, pharmacy throughout the county. Bill is a graduate of Rensselaer Polytechnical Institute in Troy with degrees in technical management, information systems, economics, and business law. So first, I'd like to welcome and thank all of you for your willingness and interest in serving as today's keynote speaker and panelists. And with that, I would like to turn over to Dr. Miller, our keynote speaker, for his presentation. Mike?
Thanks, Gordon. Can you all hear me? Okay.
You can?
All right, great. So thank you, Gordon. Thank you, Bob. Thank you, Oli and BCC and the Berkshire Innovation Center and One Berkshire for putting this great series together. I've managed to catch a few of the other ones. And this one about healthcare, I think, is very exciting because I always think healthcare is exciting. But really my focus is going to be to try and create a context and a framework for understanding how innovations in technologies get developed and get adopted by healthcare, and really try and set the stage for the three other people, the panelists, to do a deeper dive into some specific areas around information technology and healthcare and how it's transforming it. So first thing is, if you look at the future of healthcare, there's sort of two things I always want to think about. One is you got to look to the future. And Yogi Berra said, if you don't know where you're going, you'll end up someplace else. So I think we always got to think about what we want our healthcare system to be, what do we want it to achieve, what do we want it to provide for us. And then simultaneously, you got to look at the past, because the flip side expression is, if you don't know how you got to where you are today, you're already lost, which really means you've got to understand what the healthcare system is now if you want to try and improve it and build upon it and adopt innovations. And I think in the reading list, there was this great article from Atul Gawande from 2009 about explaining how different countries got their healthcare systems. So really the three things I'm going to talk about is, what is the US healthcare system today? If we want to adopt innovations and improve it, really to know what we're starting with, and how healthcare decisions are made, because that really reflects how innovations can be adopted into that process of healthcare decision making, and then really what drives the changes of an adoption of innovations in healthcare. And then I'll make some final concluding remarks before we can get to the panelists. So the first thing is, people talk about the US healthcare system as if it's one thing. And I'm going to make the argument it's a lot more than one thing. A lot of people talk about the delivery system as if it's the healthcare system, but it's really, they talk about like the hospitals, the doctors, the pharmacists. That is part of the healthcare system. There's also financing, which really insurance companies, Medicare, those kinds of things. And there's also research and public health, two areas that are very important in the overall healthcare system that really haven't gotten much attention, although with COVID, they've certainly gotten a lot more attention. And they all, in this very simplistic Venn-like diagram, they all interact and affect each other. But they don't exist in a vacuum, because there's also this new yellow sphere, called social services that really is important for determining how well healthcare delivery, public health financing, how well that actually improves the health of individuals and communities. And all of these 5 circles exist in this broader community, because everybody who's got a healthcare problem doesn't spend all their time in the healthcare delivery world or with social services. Most of the time they're in their community, and that really affects how their health status, how healthy they are, their housing, their transportation, the food that's available to them, those kinds of things. So that's just a broad construct at a global level about what are the parts of the healthcare system and how they interact. Going from that big global perspective down to the very individual micro level, this is how healthcare decisions are made for the individual. And this is an older slide I've used for years, so forgive the graphics, but some individual has some healthcare issue or need. They go get a diagnosis, and then there's a variety of treatment options that are available to them, in consultation with the clinicians. It can be medicine, can be surgery, lifestyle changes, or other things. And how effective it is depends on a variety of factors, their own genetics or physiology, the pharmacology, if it's a pill, was it the correct diagnosis? And there are other factors. And then what happens? Were they cured? Was the disease or symptom controlled or resolved? Or was it a treatment failure, maybe because it was an incorrect diagnosis? And then this process can go around for each kind of healthcare need. And of course, individuals typically have more than one healthcare problem at a time, particularly as you get older. So this cycle can continue. This circle system graphic I have here is important because all of these things are connected by data, and they can all be made better by better data and better data analysis, and better communications and information technology. You look back 40, 50 years, it was a very different process and flow of information than what we have today. So let's go from the macro down to the very micro. And I want to just put up this slide of pictures of friends and family in terms of, you got to remember the individuals are also a wide variety, ages, sex, lifestyle, life situations, as well as obviously different genetics and underlying health factors. Going back from that individual to back to the big picture, individuals also don't all have the same healthcare needs, obviously. And by that, they also don't have the same healthcare spending representation because they have different healthcare problems. What's not recognized often is that the healthcare spending is skewed very dramatically across the population, with 5% of the people representing about 50% of the spending. That's that little red slice and black bar. They are representing this 50%. And this is the US healthcare system, or the entire US health population. But the same 5%, 50% is true if you take any big group of people, whether it's people in Massachusetts, people in Medicare, people who are insured from a big company. It's that 5%, 50% roughly holds true. So we want to talk about innovations and how they're created and how they're adopted. Well, innovations don't happen randomly. They build upon science, and I'll talk a little bit more about that. But once an innovation is created, is it adopted or is it discarded? There's a guy, Everett Rogers, who did some work back in the 60s about adoption or diffusion of innovations. And he came up with these 5 factors, which are really important. The first is the innovation, does it have relative advantage? And usually that's financial. Can it save money? Can it do things more efficiently? And it's also true in the healthcare, does it provide a better clinical outcome? These next 4 factors, is it compatible with the way things are done currently for both clinicians, hospitals, patients, whoever? Is it simple, easy to understand, easy to use? Can I observe it? Or do I just have to go all in and hope I can do it? And can I even can I try it out, this trialability? And the reason I've got the nursery rhyme, the butcher, the baker, and the candlestick maker is everybody comes into an innovation or is presented with an innovation. They're coming with their own existing ways of doing things, whether it's a clinician, whether it's a hospital, whether it's the patient or something else, some other part of the healthcare system. There's a great example of a new treatment for diabetes that failed in most of these 5 factors, and it was a big flop. And innovations, as I said, happen in all parts of healthcare and diagnostics, in the information technology we're going to talk about today. Medical records obviously used to be on paper, they're now electronic. Telemedicine was growing, and then COVID came and it's just exploded. Telemanagement, telemonitoring, have also been advancing very dramatically. I've done some projects related to telemedicine or telemanagement for intensive care units, as well as some home-based sophisticated telemanagement, telemonitoring for people with some serious health problems. And then of course, treatments and medicines is an area I've worked a lot in, how those innovations are created and adopted. I'm not going to talk about that. But one thing I want to point out is that most innovations start in being used in the most acute or serious settings, and then transition into being used in less acute settings. Like this telemedicine for ICUs started in intensive care units, and then it's been used in step-down units, emergency rooms, even ambulances. This is just a quick slide, again, I've used for years about innovations in medicines, just to show that it's the science creates opportunities for innovations that can be then used in healthcare. In this case, it's biomedical science. In information technology, it's really like computers and internet broadband and IT access. Those kinds of things we have today weren't available 10, 20 years ago. So those advances have made possible to do things today that we couldn't do before. We're going to talk more about that, like the tele-ICUs or home management. Getting back to the whole US healthcare system, the context of where we are today and where we're going. These are just a few of the major changes that have happened to the US healthcare system that have caused, I won't say seismic shifts, but major changes in direction or major advancements. The FDA was created in the early 1900s. World War II gave us employer-based health insurance, Medicare and Medicaid in the 1960s, managed care and HMOs, and something called capitated payments in the late 80s into the 90s. HIV and AIDS had some dramatic shifts in research and public health. The Medicare prescription drug benefit in 2006 changed the relationship between insurance companies and the pharmaceutical industry. The Patient Protection Affordable Care Act in 2010 was also a major shift. And one thing it didn't get a lot of recognition for, and people still don't talk enough about this in my opinion, is it actually started to change the business model for insurance companies. Before the Affordable Care Act, the basic business model for most insurance companies was avoiding risk, avoiding those 5% of people who represented 50% of costs. The Affordable Care Act started to flip that on its head and make it so that their business model was more, how do we get those 5% of people with all those healthcare costs and provide them better healthcare, working with health delivery systems so that those costs can be, not eliminated, but reduced. And that was the business model. So meaning instead of avoiding risk, they were actually seeking out the high cost people with a lot of health problems to try and provide them better care. And then of course, COVID-19 has really changed a lot of things in the relationship of healthcare, public health, research, and other things. So looking to the future, just a few quick areas. What's going to happen post-COVID? Is public health going to be a priority? Is it going to be connected to healthcare services more? Is it going to strengthen the relationship between those two circles? What's going to happen to the ACA is a major question. Will insurance companies go back to avoiding risk, or will they continue to move forward working with healthcare delivery systems and clinicians and health systems like BHS to try and reduce costs and improve care? And then, of course, what we're going to talk about now is technology developments and adoptions. Will it make financial sense and clinical sense? And in some ways, that financial calculations and clinical calculations relates back to how the financing system works and how the ACA and related parts of health insurance evolve. So my conclusions, we're coming into a lot of great opportunities using data and information technology like telemedicine, which some people knew about pre-COVID, but sort of everybody knows about now because it's really exploded. But this telemedicine or healthcare IT really has exciting opportunities for improving care for most people with healthcare, because unlike a new medicine, which may affect a small percentage of people dramatically, some of these high health IT improvements really can affect a lot of people, not just those 5%, but the 75% of the population. But the questions remain how they'll be adopted, what incentives will be created for using them. And I come out of a little bit of a budget policy background. Will it make sense financially for insurance companies and clinicians, health systems, and for individuals to adopt and use those innovations? I think that's one of the big questions. So I want to thank you for your attention. I think I've taken my 12 or 13 minutes. Look forward to the panel and for questions. And again, thank you for all the sponsors of this and for Gordon and Bob for putting it together in such a great way. And Gordon, I'm going to stop my slides now, right?
Sure.
So we can all see each other.
That's great. So Mike, thank you so much for your, comments, a great overview of our healthcare system and where technology fits into this. Obviously, it's just one piece. And, as I was thinking about your presentation today and the kinds of transformational pieces that we were going to be looking at, I thought of two things that really have supported or underlie what we're seeing or the fruit of this technology transfer today. One of them, of course, was the work back in the mid 20th century, which is work from Watson and Crick, both in the discovery of DNA, which has led now from its early forms to highly evolved and highly sophisticated uses of that. And of course, the second piece of that is the internet, which has transformed not only our non-medical lives, but certainly in medicine, as well as a lot of things, and you alluded to them, that we're doing now because the internet exists. If it didn't, just think of what it would be like in COVID-19 to try to manage care, remotely and independently. And so I think that, the last thing to say is, and you reminded us of the ACA, I certainly hope that we're not disappointed in the next 6 months to learn that that's going away as well because of some political issues. So, so just to start this off, Mike, I'd like to just ask you to think about, looking at the transformational technology side. It's great that we've made the kind of progress that we have made, but I think there are also a number of barriers that we have to deal with. Some barriers that are technical, some that are operational. Certainly cost is one, because these don't occur in a vacuum. And lastly is public acceptance. I reflect particularly now, again, in the middle of COVID, when you get a call from your doctor that says, I'm sorry, you can't come in, but we will do a telemedicine visit. I know a lot of patients aren't that happy with that. I mean, it's not their preferred choice. There's a workaround, but it's not what they want. So just, if you could just think about that and reflect on this technical barriers, operational barriers, cost barriers, and then patient acceptance barrier, I'd like to hear your thoughts on that.
Yeah, I mean, the barriers really depend on who's the user for a technology. There are certain technologies that happen in the hospital that it's really the hospital system and the clinicians have to be acceptance. The work I did on tele-ICUs, there was some very significant barriers for that. But once the clinicians saw the great benefits, when it started saving people's lives and how it improved the quality of care, then there was great acceptance. But if it's something where the patient has to use it, then it's sort of a different set of use acceptance. Then there's obviously the financial things. It's very hard to convince a hospital system or clinicians that they should spend a lot more money on something that's maybe going to have a bit of improvement and make the lives better for patients, but it's going to end up losing them money. There's an innovator, it's not information technology, but another kind of innovation, somebody out of Vermont, for people who are very sick in intensive care units, but it's going to cost a significant amount of money, not a tremendous amount for hospitals, placing something that's $30 with something that's $500. It probably makes clinical sense and probably makes economic sense, but making that argument is something you've got to be able to articulate to the people who are making the decisions on what to purchase and what to use. It can be a long discussion. I appreciate your comment about Jim Watson. I actually work in the office next to him at the NIH briefly. I was just thinking I'd go behind me and get my signed copy of his book. But also,
Mike,
when my dad was in what's that?
Can you explain to our participants today, what tele-ICU is? I mean, I thought it was fantastic when it first came on the scene, but it may not be obvious to them what that is.
Basically, it's instead of telemedicine between a clinician and a patient, it's a sort of a NASA-like setup with multiple screens and data inputs and computers, where you've got clinicians, doctors who are trained in intensive care, nurses who are trained in intensive care. They're at that command center watching patients with cameras. They get the data feed from all the respirator and all the different information. They can look at all the labs and everything else. And they're there, and their only job is to help monitor the patient. Whereas the clinicians in the physical intensive care unit are there, they're monitoring the patients too, but they've also got to be administering the hands-on clinical care. So the tele-ICU people in that command center can be monitoring the information, the vital signs, and that information they can run through algorithms on their computer systems, and it helps them identify, oh, this person looks like they may be going in a bad direction. The semi-clinical lay term is they're getting ready to crash, and they can, by seeing if they're heading in that direction, work with the clinicians at the bedside to try and figure out what's going on and try and forestall that. And it can save lives and get people out of the intensive care units a lot faster.
So this is a solution.
It takes coordination and teamwork between those two sets of clinicians.
So this is a solution, perhaps in environments where there are few intensive care physicians, or more rural settings or cost settings, where a hospital located in northern Maine that certainly can attract intensivists can still care for them, albeit remotely.
That was the original value proposition, if you will, where there's a hospital that had intensive care unit beds but didn't have a physician trained in intensive care who was in the hospital for 18 hours a day, not one, but covering multiple shifts. If that clinician wasn't there, then there was really a problem for patients who really were very unstable. And you're right, because one command center, tele-ICU command center, can provide that management monitoring to multiple hospitals, multiple intensive care units. And actually, one of the benefits of it, and I won't digress too far, is that by having one command center managing and helping multiple hospitals, it meant they all had to get on the literal same page for their protocols for how to care for patients with certain conditions, how to improve, how to manage quality, how to prevent things from happening. And once they were all on that large extended team, it meant that they could also improve and update their practices much more quickly, because they couldn't have, one command center couldn't be working with 6 different hospitals if they all were doing different versions of the same protocol or different protocols. It was really, once everybody recognized that, it became like an aha moment, and everybody saw the value, and it really could catch on.
Thank you, Mike.
And it's also, as I mentioned, it's now being used step-down units or in ambulances, emergency rooms, and other places as the technology's gotten smaller and faster and better.
So I'm going to bring our panelists into the next phase of this presentation, and we'll probably end up with all 5 of us in a conversation, and then we'll bring our entire audience in through the chat. But specifically, I'd like to ask Dr. Sproul, Joe Diver, and Bill Young, in your particular roles that you now serve and in which you are right in the front lines, can you just reflect on which of many transformational technologies or new technologies you think is having the most profound or impactful, is most impactful within the community in areas that you serve? And maybe we'll start off with Chris just to start, and then we'll go to Joe and then Bill.
Sure. Thanks, everyone. Thank you, Gordon. And thank you, Mike, for the introduction. I think speaking from a physician-patient perspective, certainly the electronic health record, which has been developing literally, folks may not know this, since the late 70s, but really started to come into acceptance and use in the early 2000s, I would say, with robust adoption. That's certainly allowed better communication among physicians, between physicians, hospitals, laboratories, ancillary service providers, and even patients. That's not to say that we use it really well yet. That's not to say that it's all that useful. In a lot of cases, it can be usable, but not necessarily useful, as folks may know who have bumped into that from the patient perspective. But that is certainly one thing that's helped us. I would say more recently, the kind of low adoption yet, but the promise of certain biometrics and wearable devices is something that we look forward to, maybe getting into greater use. They're not quite there yet. We don't have a lot of data behind them, but certainly they have been in use for a while. The space program uses them, the military uses them. And we also know, if you have a pacemaker or know someone who has a pacemaker, we've been monitoring and manipulating pacemakers for decades now via the phone. So that technology may not necessarily be all that new, but the widespread aspect of it is. And one thing I really look forward to is the combination of all of the clinical data we now have access to through our EHRs, coupled with a new intelligence system. I'll hesitate using kind of the vernacular in that, but some other intelligence system that puts things together for us in a way that we can become more clinically effective, more timely, and understand what works and what doesn't. Folks may not know that in healthcare, all kinds of healthcare, not just medicine, we actually truly know very little, and we make educated guesses about a lot based on data, based on evidence, and based on experience. But if we can get artificial intelligence or some other intelligence system to couple with the data bank that we're now accumulating to work on clinical effectiveness, that would be awesome.
That's a real good point. Thank you, Chris, for bringing electronic health records into this. And just to remind our participants, one of the real kicks in the arm for electronic records occurred at the beginning of the Affordable Care Act, with lots of money for what's called meaningful use. And then maybe either Joe or Bill, who I know have a lot of experience in their roles as the CIOs, can talk about meaningful use and how, to take up Chris's point, how electronic health records have just transformed the way doctors are practicing. Joe, maybe you can, I don't want to force you into that subject if you have something else you'd like to talk about first, but let's just get back to it at some point.
Yeah, no, absolutely. I think it kind of links across the last number of years that the meaningful use drive by the feds really set the foundation. And I think historically, the early days of meaningful use was not as transformational as it could have been, but it did set the right direction at the end of the day. So early days of deployment of computerized physician order entry and bringing evidence-based alerts to improve that workflow and the safety for the patient. So I think it set the right foundation, and Chris hit on a number of great points. And with that foundation provides us the opportunity, I think, in very localized areas, for example, out in Springfield, to leverage data through artificial intelligence to help predict where a patient might be headed in their care, specifically on the inpatient areas for minimized pressure ulcers and things of that nature. But where I think with COVID, and my heart, always is touched by hearing stories about patients who are recovering, but also saddened by those that didn't make it through that crisis. But it forced us to leverage digital health differently and relatively quickly. And that's where we saw a good advancement of the telehealth services. I think everybody had the same experience because it was the first technology that we could go to. And to Mike's presentation, what really unlocked that opportunity was the reimbursement changes, because it's a big investment for that technology, but the payers and the feds and everybody lined up and would say, okay, we'll reimburse you for that activity. So that was quite helpful. And carrying that ball forward, some of the things that, in tying back to Mike's presentation about the triability of innovation and the experimentation, is we're in the middle of that in a couple of different use cases to bring patients into their healthcare as a partner with digital health solutions. For example, hypertension management and diabetic management. And I'll share a quick story that kind of goes back a few years ago, working with a very large health system out in Virginia. They leveraged a new technology for glycemic management control and set it up as their new standard of care. Because what happened is that more and more patients that were coming out of critical care, their blood sugars weren't being controlled, which leads to infections, which leads to longer terms of stay, which leads to higher costs in care. And they actually standardized the new glycemic management across 12 different hospitals because of the impact. But that's just another example of how do you make the investment to see that outcome return on the other side. And that is the big challenge within healthcare right now is where the financial connection. I think I saw a question somewhere that, how do you basically deliver that technology to consumers, and where do those dollars flow in and out? And what my focus is right now is really looking at value-based care, and because I think that's going to tell us a lot on how to look at the financial circle, if you will. Most health systems, if you run on a 2% margin, I think you're doing pretty good. If you're in any other industry, you would probably close the doors pretty quickly. So those are some of the challenges. But your question going about meaningful use, I think it did set the standard and the foundation. And now it's a matter of how do we leverage this technology and make the right investments for our community. And if you look at any community needs assessment report, which health systems are required to do, I think you'll find on average 30 to 40% of healthcare costs are related to social determinants of health, which is a whole nother topic of discussion down the road. So I hope that's helpful.
Yeah, thank you, Joe. And one of our participants actually, while you were talking, sort of postulated that the meaningful use piece was tied to some money. I won't get into the details of it, but the answer is yes. Yeah. There was some significant dollars that were tied to it to get people to actually do it. Bill, do you want to weigh in on this general topic, not just EHRs, but transformational technologies from your point of view?
Sure, I'll try to add to what my co-panelists just came up with. And yes, the government was very helpful in giving us money through meaningful use. Berkshire Health Systems received millions of dollars from the government. Interestingly enough, and I think that's true with most healthcare systems, we invested millions more than the government gave us, right? So I think most of the investment that pretty much every provider, every healthcare system made probably outperformed the money we got from the government, which the government did a good job of helping us with maybe what we could call EMR, EHR 1.0. And I think the cool part is we're in the second or third wave of that, most of us, right? Many of us have been on an EMR back in meaningful use days, and we've taken a quantum leap, I think, many healthcare systems. So we're on version 2 or 3. I think the other things that are happening, even with the initial meaningful use, they pushed us to do a patient portal. But I think, again, version 2 or 3 of that, the integration with our patients is huge. I think the integration with other healthcare systems, right? It's still something we're getting better at. For me, with both of my partners, with CHP and Baystate, it's important that we're sharing data. And I think we've still got a long ways to go there. We're not where we need to be. And I think that's still maybe in version 3, 4, or 5 coming at us, but we're making improvements. And I think the other thing that I wanted to say is all these technologies coming together. I look forward to healthcare shifting from, Dr. Miller had the slide of kind of how healthcare works right now, which I think is very true, that something usually goes wrong. Something bad is happening, and that brings somebody to healthcare. And then we're addressing some issue in healthcare. And then again, there may be multiple issues, but I really think we're heading into an era of more holistic care, much more personalized care, much more looking at the patients, looking at the community. Like in the Berkshires, we're moving into ACO, accountable care organization models, where we're getting paid to take care of the community, not necessarily just being paid on what we do to help care for an issue with people. And I think the technology is supporting that transition of sharing data, integrating with patients, integrating with families. Telehealth, the benefit of being able to bring care providers wherever they are, right? We in the Berkshires may need some care providers that just aren't here, and we need to bring them in. And telehealth, being able to bring them in with primary care, with the patient, with the family, with the primary care docs, I think is a huge transformation that is just kind of in its infancy yet.
Thank you, Bill. So here we are. We've got a lot of technology on the shelf. I think Bill alluded to it right up front that all these things are expensive. So a tool may be out there or at least it's being promoted out there by a vendor to perform a particular task. It may not be all that well vetted. And we're in a country that is very entrepreneurial. So there are a lot of organizations that are promising that the product is a breakthrough that you just can't live without. Especially if you look at our television every night on the drug side, there are drugs that are marketed to us that you just can't spend another day on this earth unless you get your doctor to prescribe that for you or your prescriber. So I wonder if you could just really talk about, and this maybe comes into the question I posed to Mike earlier, some of the barriers that you are seeing in terms of implementation of some cutting edge technologies. Good stuff that's out there, but it's very expensive and its really long-term impact is not as clear. And just wonder if you can talk about that as well. And also the patient acceptance piece, the operational challenges, you've got to build a whole staff, things of that nature. And I don't know if any of you should feel free to chime in on this, please.
Maybe I'll start and maybe go in the back order. That finances are a huge part of it. Healthcare operates on razor thin margins. I think someone mentioned I think it was Joe, if we're getting a 2% margin to reinvest in things, that's super. And especially with COVID, we've lost millions, and many of us are not living on 2% margins right now. And many healthcare organizations are living in negative margins. And that's just a real challenge to make these kind of investments and make them work. Fortunately, I think, like we just said, the changes in the reimbursement with telehealth was phenomenal. I think the push of COVID, the changes that let us get paid for the work we're doing was huge. Maybe the other thought to bring up, technology, people, and process. It takes all three to make things happen in healthcare: technology, people, and process. And in many ways, technology may be expensive, but it might be the easiest. We struggle to change people, change culture. And that's still very huge in healthcare, right? To change how we do things. So maybe I'll turn it back over to my friends here.
So
Yeah,
Chris, Joe?
You spot on, Bill. And one of the philosophies I have is that technology is 20% of the equation. The other 80% is what we're going to do with it and who's going to use it and leverage it across the board, from clinicians to nurses to patients to administrators, whatever the case might be. And I think those are some of the challenges as you look at new technologies and taken into a context of human-centered design. I think is one thing that EMRs missed many years ago, but are stepping up to nowadays. And I saw a comment that someone asked us to explain the EMR and see it's really the electronic medical record. It's your entire medical record, all your labs, all your vitals, all your documentation from the nurses, administrative records, financials, et cetera. And it's within the context of a workflow. If we implement technology that takes a physician or a nurse or someone outside of their normal work stream to leverage the technology, becomes a pain. So integration, interoperability solves that to some point, and there's new interoperability standards, which makes it a little bit easier, but not everybody's at the same level yet at this point. And if you look at some of the investments that you could make, if you look at, and there's another question in there, someone asked about the Affordable Care or Medicare for All, I think it was. And if you look at the ability to tie all this data together, it's a huge investment. So we're 3 different health delivery organizations. our patients go between all three health systems. And just in the region, we're not really connected as well as we could be to share data and know more about our patients and know more about their family history. That would be a great investment from a community perspective. But where does the return come from? So those are some of the challenges. So people, process, technology, workflow, and then how do you financially close that gap? If we can solve that, we'd solve a lot in healthcare. But those are some of the major challenges. I hope that's helpful.
Yeah, sure. Those are all really great points, and I appreciate them. I think, one of the things we have to keep in mind, and this gets to the point about interoperability and affordability, is that most of these technologies are still in the hands of privately held or maybe publicly held for-profit entities who are still looking to make money off of them. And we also see in the news pretty regularly, we had a few CEOs being questioned and testifying on Capitol Hill the other day, that standards across technology, internet companies maybe don't exist as they do in other industries. So for instance, the question of interoperability, and this was brought up in the chat room, and Joe just mentioned it, it's very difficult for us to talk across platforms. We don't have standards like ATM machines in the banking industry have standards so that I can go to any ATM and get money out of my bank. You can't go to any EHR and get information from another EHR. It just doesn't work right now, and hasn't, and it's been a problem for years and years. And although I know the government has tried to address this, the standards have not been set. So interoperability really does not exist yet in that regard. It is not easy. And there have been lots of workarounds developed, but it is very expensive. The other thing I think we need to consider, as well as the opportunity costs that Joe mentioned and the individual investments that Bill mentioned, is the investment on the part of our patients. So they all, if we want this technology to work, they have to be able to connect with us. In some places, like where I'm sitting right now, the cell service is not very good. I can find places around here pretty easily where internet access is not very good. And I also know that we have lots of patients at a federally qualified health center that can't afford the cable bill to get internet access. And we've seen that with COVID and our students who actually can't get there. And I mentioned wearables before. Those are great, right? We employ them on the battlefield. Our soldiers wear full vests with them, so do our astronauts. But the government usually has lots of money, your money, to work on those. Right now, without data, there's really no one who's going to pay for those. You can go out and buy your own Fitbit, and we can download data from that. There are a few things, right? We can get your glucometer or your pacemaker paid for, but there's evidence behind them. But until that evidence is developed, those things probably aren't going to be paid for by anybody but those folks who can pay for it out of their own pocket. So there's a concern around disparities in the implementation of technology as well that I think we need to really make sure that we're addressing, because we'll create even a greater split between haves and have-nots in that regard. And then, if we really want to make that move, as Joe mentioned, from kind of over to a value-based system where we're really doing the right things for folks, and we're employing these technologies that may be helpful, we really have to get away from a national payment system where we pay physicians just to do things, right? Right now, we pay them to visit with people. Fortunately, and this didn't happen until COVID, believe me, the technology has been around. I can do a phone visit. I could have done a video visit or an asynchronous email visit with patients for a couple of decades now. But that time would never have been compensated for, right? Until just very recently. And it took a disaster like COVID to bring that up. And right now, we quite frankly have concern that once COVID has passed, whatever that means, that allotment will, or payment reimbursement will go away again. And that's a real concern, because there's a lot of stuff we can do through remote care that's way more convenient for people, right? And I think there's going to be a lot of folks that don't want to give up on that convenience. It's not only convenient for patients, it's convenient for providers as well. We like it. So, but it's really hard, to keep doing that without being able to even pay to keep the lights on.
Yeah.
So we'll have to figure out some of that stuff too. But I have a big concern around the cost that may end up in patients' laps around technology. I know we've struggled with it as providers, and it would be a real shame to see it end up there.
Yeah, I guess it comes up. I'm sure it comes. I'm sorry, Mike, did you want to say something?
I just wanted to build on what Bill, Joe, and Chris had talked about in terms of interoperability. And just to clarify for the audience, interoperability means really that one electronic medical record system
Thank
can
you.
send its information to another, and they can talk to each other. As Chris said, ATMs, they can all look at your bank account. The problem is bank accounts are just numbers of dollars, whereas your health record is a much more vastly complex system. And the pot of money before the Affordable Care Act that went to help create meaningful use, which is really means electronic medical records that provided useful data that had meaning to it and was useful, as opposed to just a replication of paper records. That pot of money also had a piece of it, or a parallel piece, to create these regional health information sharing organizations, so that, and it's slowly evolved, where if the two electronic medical record systems couldn't talk to each other, they could be sort of a communal data aggregator. And there's some of those around the country. I worked with one in Cincinnati that was actually one of the first and longest lasting ones, but that they've got their own problems. Here in Massachusetts, I know in the mid 2000s, they tried to create 3, including one up here in the Williamstown, North Adams area. And you talked about barriers, Gordon. One of the barriers to doing something like that is just the technology. It's not even the money. It's the technology just doesn't exist to really put that information together in a useful way that then can be provided to the doctors out in the community. So if somebody who's been at Baystate suddenly ends up in Pittsfield or in Albany, that somebody can access that data repository and get what they need. Because all they're getting is billing information that doesn't do them any good. So there's a technology, but then there's also what Bill talked about is the culture of, do the different health systems really want to cooperate and pull their data together in a way, and who's going to pay for it to happen? And then Chris pointed out the very realistic US capitalist situation where the different electronic medical records companies, they really don't want their information being shared. One of the biggest ones has its own data repository system that it wants everybody everywhere to buy into, because they want to sell their system to everyone. And I won't go into naming it, but you all are smiling because you know who I'm talking about.
We could have a whole conference just reminding us of how our capitalist system has both helped us in many ways to be highly, entrepreneurial and developing innovative products, but at the same time has hurt us in exactly the ways, Mike, that you just sort of outlined.
But one of the other opportunities I want to point out is coming out of COVID, that kind of data integration analysis can really be helpful for public health and community health, and an area where it's created an opportunity that hasn't been utilized is around substance use disorder, behavioral health, mental health. Because a lot of times people with those kind of chronic conditions are going to a lot of different providers. And if that information isn't put together, then every time they see a clinician or a healthcare provider, they're getting substandard care, because that person who's trying to help them is only seeing bits of pieces of what is going on with them, is what's been done for them. So that there's a lot of public health value, and hopefully coming out of COVID, that can be recognized, and the money can be said, okay, we're going to put it into, whether it's interoperability or regional health information organization, something to create better data utilization for healthcare and public health.
I'm sure that our participants were, I don't know if the word stunned would be right, but it would certainly be surprised what Chris reminded them all, which was that prior to COVID, there were only very limited circumstances under which physicians and health systems could be reimbursed for remote so-called telemedicine. And therefore, that was a major discouraging factor in not only developing it, but in enhancing it. Maybe, right now, if you have a televisit, most people don't have blood pressure cuffs that can transmit their data, or have an oximeter that they could put on their finger and tell the doctor what their amount of oxygen in their bloodstream is. So, we could go a lot further with that, and yet there's noise coming out now that, oh yeah, we're going to pay you right now for this, but when this is all over, quote unquote, we're just going to go back to the same stupid system that we had before.
Can I point out one thing, because this is an
Of
area
course, Mike. Yeah, of course.
delved in the policy world, is yes, most insurance companies who pay for each individual activity, so-called fee for service, weren't paying for telemedicine at all or very minimally. But health plans, managed care organizations, HMOs, they actually were paying for it because they had the discretion to decide what they're going to pay for and what not. So there was a whole rhetorical trope about Medicare doesn't pay for telemedicine services. But a third of people in Medicare are in managed care organizations, and those so-called Medicare Advantage plans, they were providing telemedicine. So this is all part of the whole evolution of financing and what's coming out of the ACA. And for hospitals and others that were suddenly at risk financially for bad outcomes for their patients or readmissions, they may have had a financial incentive to say, yes, we're not getting paid for that individual telemedicine service, but it still makes financial sense for us to do it. So that's, again, where my two spheres of delivery and financing come together, and where there can be a financial incentive, even though it's not like we're going to pay for it individually. But Chris is absolutely right. Because there was no other way to provide care with COVID, everybody said, yeah, we'll pay for it. There's not going to be any co-pays. Just do it because it's the only thing that it's got to happen. And what happens afterwards, I think, is a big unknown. But hopefully people will see the lessons and move forward. And one of the areas clinically it's been shown to be great is telepsychiatry. That's been shown for the last 4 or 5 years. Better outcomes, better adherence, clinically and economically.
Gordon, if
Yes,
I could
please, Joe.
Just real quick, Mike hit another point, because the other side of the financial side is for the consumers of healthcare who are in the employer insurance market, and their costs are going up, their direct copay deductible costs. I just want to give a shout out. Someone in the chat talked about their own glucose numbers never been below mid-7. And being an apprentice in your care and knowing what to do and being ahead of the curve is going to reduce your own direct cost long-term, especially if you're in that employer insurance market as well.
We're going to transition at this point to let all the folks that have put in chat questions, but I just want to sort of end our little formal discussion with sort of a bit of a high note, so that we don't lose sight of what's been accomplished. Mike alluded to the public health side of it, and so I jotted down a couple of things that we as a society can be proud of. On the public health side, we could certainly say, I'd say the remarkable and rapid progress in the development of a vaccine, and we will have it shortly, for this pandemic has been an unbelievable step. The elimination of smallpox, which was nothing to so-called sneeze at, and effective treatment for Ebola, which eluded us for years. Genetic engineering, which has allowed us to develop human antibodies grown in genetically engineered mice. These are all things that are remarkable. Robotic surgery, where the operator or the surgeon can be in Pittsfield and the patient can be in Mumbai. Remote patient monitoring, which we have alluded to before. Some of it is whiz bang and doesn't add a lot of value. I see the guy that's got his little machine that tells him his EKG. I really wonder, how much that helps. But there are robotic stuff that does really make a difference. the health records issue, which we can widely share. And then the idea that our participants can harness their iPhones and their iPads that give them control of their health system, to allow them to have a patient portal that lets them, communicate directly with their doctor, or to look at their data rather than just, rely upon less direct means. So with that all as sort of background, I want to, first of all, in case we lose a little time, to thank you all for this. We're going to ask Bob to moderate and come onto our screen. And Bob, I know if you could grab some of the chat questions, and we'll have our panelists answer them.
Yeah, it's a great discussion. And in fact, great to see a number of the panelists pluck a few of the questions off the chat board along the way. So it's terrific. There's a question that Barbara has posed that I think takes the discussion in a little bit different direction, which is interesting. And her question is about the education of healthcare professionals and the role of technology and how technology advancements has affected medical training. And that's maybe in terms of not only medical school, but how residents kind of go through in your clinical experience and so forth. Any comments about that?
I'll mention one thing, which certainly when I started medical care training and work, almost all significant surgery was open surgery. Today, meaning open, the patient, especially if it was abdominal or thoracic surgery, the patient would be opened up so the surgeon could see the field and do what they needed to do. Today, it's almost the opposite. In fact, I think there are fellowships to train surgeons today in open surgery. 95% of what we do is closed, through little endoscopes that they insert into the patient. So that kind of a technology is dramatically different, and that's sort of part of the training. The average surgeon coming out of their training today wouldn't probably know the first thing about doing a lot of open cases.
So, Bob, I think one of the things that we use nowadays, and others can comment on this, and not just in medical school or residency or fellowship training, but even for continuing training among various teams in the hospital, are our simulation laboratories. So we're able to simulate lots of different situations that happen either in the field, in the ED, on the floors, even in the offices, and then go through those with the underpinning of significant technology. A lot of the basic things we do in medical school, folks are probably aware that in anatomy lab, we dissect cadavers. In physiology lab, we literally used to do work on dogs, right? Where we would do different things to them to learn about the physiology of the body. A lot of that stuff is going away now and is done virtually and can be done remotely on students' time. So there are a lot of things in the training of folks that have come along. We certainly find, you cannot walk the floor of the hospital with a group of trainees anymore who aren't currently, like in real time, connected somehow, checking out some piece of information about a patient, whether they're actually gathering real data on the patient or looking up something that affects their care or decision making. So we do things in training both and in real time with folks, with our trainees on a fairly regular basis now. It's really remarkable. That has happened fast, like in less than a generation, right? That's been implemented.
Yeah.
One thing, can I just chime in? One thing
Yes.
I've heard and have seen is that, all the academic centers where physicians and other clinicians train have probably some of the more sophisticated electronic medical records. And what that means is when they come out and they graduate, they're rather reluctant to go practice in a community or at a hospital that has an earlier or a much less robust electronic medical record system. I know in the mid 2000s, there was a chain of hospitals in Boston that still had paper records. And they said it made it very, very difficult for them to recruit residents to come there out of the medical school, because who wanted to go from a medical school to electronic records to paper records? And that health system, 4 or 5 hospitals, actually got bought by a big for-profit chain. I think because of that, because they couldn't invest in electronic medical records and they couldn't recruit residents. It was a downward spiral. So I think that technology is really going to become a competitive thing for health systems, and is really a problem for a lot of smaller rural hospitals and communities. And I think that's something that we got to look at in the future as to how maybe round 2 of the Investment Act to try and support electronic medical records and health IT. Sorry, Bob.
Yeah,
It's a
no,
great point. Great point, Mike.
Could I jump in a little bit? Even we talk about the residents, and that's so true. They come to our system with so much knowledge, right? They come out with the knowledge of robotics. They come out with the knowledge of EHRs or EMRs. Wanted to kind of jump to maybe an impediment, but even I just give so many of the physicians credit, many of them that are in their middle career or even their later part of their career, and they were not trained on medical records. And the evolution that they've had to go through to move from a paper record to electronic medical record. I'm very blessed to have 2 doctors on my payroll that help. And, they're doing lunch and learns with their peers regularly. The changes, the improvements, the interoperability that we need to achieve, the discrete data elements that we need to work with. And so training for physicians is a huge thing to help them and it's an ongoing thing. And the world of EMRs has changed how doctors work dramatically. A lot of burden has been put on them. And I think we're starting to help make that shift where a lot of the data that has to be put in, especially discrete data, the doctors were put on the hook to do that. And I think now with scribes and assistants and medical assistants, that's changing and improving. But that's still an era that a lot of human change has had to happen, especially on the physician world.
Pre-COVID, frustration with EMRs was the #1 cause of physician and clinician burnout.
Amen. Yes.
that's really interesting. I didn't realize so much of this discussion is around data and the EMR, which I just find fascinating. And there's a whole bunch of questions about it. One participant pointed out that the VA system may have one of the better electronic medical record systems, and be interested if you have any view to that. There's been comments about the disparity and the lack of connectivity as a patient between EMRs. How do you as a patient, get your data from one place to another? So it's a very bifurcated system, and of course there are private sellers out there that are pitching the healthcare system. So we've got this hot mishmash, and then how does that affect big data? I mean, a lot of the clinical effectiveness of a physician, I would posit, is based upon access and understanding of data. You've got Watson out there that is, taking reams of data from all over the place and developing a clinical view to it. So these are some of the comments coming through the chat. Just be interested in any further comments in that regard as to, from a patient perspective and a clinical development perspective, and how AI and big data sort of manages this porridge of different data sets to affect.
We've been, I think, just in the infancy. We're gathering a lot of data. I know in our data warehouse, we're gathering data and trying to put it together. I think the next big leap is to use that data very effectively to help these doctors who are inundated with so much data, right? Bring out what's important, bring out what's critical, kind of match data from my record with Baystate's record, with CHB's record, look for patterns, look for trends that we can highlight to the primary care specialists that something's going on here before it happens, and let's help make those changes. And I think that's the next era we're headed into, but we aren't there yet. We're gathering a lot of data, we're storing it, we're trying to normalize it on the patient. That has been a big challenge all by itself, just to bring all the data together and make sure it's the same patient. But now to really use it, I think, is our next big challenge.
When will that happen? When does the panel feel that we'll make progress and be able to talk about a better, more integrated data view for patient care?
Yeah, that's, I'm sorry, Joe, to jump in on top of you. That's a really good question. I will tell you that I'm disappointed with the progress in that area. And I think there are a couple of things that hinder us. But let me just back up a little bit and say how we might use that, right? So right now we rely on various types of publications, papers, right? Trials, clinical trials that get published in a few years. After the trials, already taken 7 years, right? And then maybe we adopt that, which takes a few more years. The data that we've accumulated, right, either through the EHRs or payer databases, right? We should be able to use that in a way that supports how we move through what's called a differential diagnosis for a patient, and then treatment options, right? So right now, when we visit with a patient, we kind of listen to their story, right? What they've been experiencing, the context in which they've been experiencing it, the social setting and things. And then we usually go through a bit of a physical examination. Right now, a lot of things are remote, so maybe not so much, but we do. And then, we come up with this list of things that it might be. Well, we could certainly use a lot of help with narrowing that list, right? Because that will also help us narrow the numbers of things that we might do afterwards, like to gather more diagnostic information. Which is expensive and can be complicated and cause complications for patients. So that's one of the ways that the data could come together. But in terms of a technological challenge, we've talked about the lack of interoperability of the systems that we all use, right? Like on the screen right now, there are at least 3 different systems represented. Technical systems. We would have to physically pool our data together, right, to come up with a really good data set where we might be able to make some care decisions. So there's an opportunity there. How do we, on a large scale, pool data together? Before I mentioned the proprietary nature of some of the technology. Well, everybody knows data is one of the biggest, sources of proprietary information out there, and people treat it that way, right? There are huge payers out there, I won't mention them, developing companies that are all around data because they know how valuable that is, but they won't share it without our paying for it and then putting it to appropriate public health use. So there's a real problem with that. And it's one of the biggest challenges we have is being able to get that data together, go through it efficiently, right? And then use it for diagnostics, for treatment, for diagnosis, right? There, again, it's like there's no standards around this and we haven't had public conversations about it. The data exists, it's in silos or in hands of folks that really do want to make a bunch of money off of it, and it's not all coming together.
Can I just make one quick point? Bill and Chris talking about the data and EMRs. For the participants, people who are watching, just understand the difference between healthcare data and like what's in your bank account and financial and everything else. A lot of that, I won't even call it data, I'll call it information that's in an EMR. It's in text. It's like the old doctor's notes you just write down. It's not just numbers related to lab tests and everything else. And analyzing that can be very complicated. I do know somebody actually working with the VA, I believe, that's using National Security Agency technology where they, the NSA can screen a gazillion emails and texts looking for code words or hot words or something. They're trying to use that to analyze what's called the free text of electronic medical records. But it's technologically very challenging. And that's where in that free text, is where there's a lot of useful information, but aggregating it and analyzing it is very complicated. It's not just like looking at bank account records.
And then I'll just sort of add the other side of the equation. I've recently had some medical issues that I've had to have attended to. And in each of these practices, and they're not backward practices, and they're both in Springfield and in Pittsfield, the practice hands me a 7 or 8 pages of to fill out for them. What's my medicine? What's my this? What's my that? I guarantee that information does not get transferred to the medical record. I think maybe the doctor or the nurse or the PA or the medical assistant uses it to, to sort of, it's a quick way to get a medical history, but that information gets lost in time. So I feel like it's like 1957, when I fill that out. So we've got challenges in a lot of that space.
It gets there, Gordon, but it's just a PDF that gets scanned into the EMR. Which is a whole nother
That's
issue.
very helpful. Yeah.
Right, exactly.
Not.
And
It's the text information that's not really data.
that's right.
That's exactly right.
And we're doing some innovation work around the text data, trying to figure out more social terms of health within the record, because it's buried in that text document. And what else can you do with it? There is so much opportunity. And Gordon, you had asked a question about when, I'm not sure if Gordon or Bob, when do we see this will get there to another level? And it's interesting. I talked to a lot of different health systems from an innovation perspective, and the consumer drive and what they're doing within their individual markets to retain that loyalty is where they're making the investments. If you don't have that external pressure, it's hard to make those investments. But I think it's going to take us to at least, if I'm at the blackjack table just putting some money down, 2030 the earliest, because there's a lot of work ahead of us, but also a lot of investment and a lot of policy changes by the end of the day. But consumers will certainly drive that need as well, because they may have choice in different markets. Our market might be a little bit different, but if you go to some of the bigger cities, consumers have choice. That's going to be a big driver.
They do. Let me just ask this question of the panel, focusing on the Berkshires. Are there particular technologies or healthcare trends that would most benefit our community during this COVID period and the near term directly afterwards? Any advancements that you would feel we could point out, aside from telemedicine, which I think is fairly obvious to everyone? And then as we look forward, what's our capital structure to fund some of these advancements? And the panelists touched on this. It's the the dollars, and health systems, physician practices, and so forth are being very stretched right now. You have your thoughts about the key technologies then that you see being applied during this COVID period and in the near term thereafter in this context?
Could I jump in and start on this one? And I'm not sure it's even a technology. I think some of the advancements are really getting into things that are sort of outside of healthcare, but how important they are to healthcare. Somewhere earlier we mentioned all the socioeconomic things that impact healthcare, and in the Berkshires, so much of our population is on government, Medicaid, Medicare. There are a lot of social economic issues they're impeding healthcare. And over the past few years, with the move to ACOs, accountable care organizations, the state has helped sponsor Medicaid ACOs, where they've given us some money to really try to learn how to take care of people. And many of these people are in situations that healthcare is impeded by other things in their life, getting food, getting transportation, things like that. And I really think a huge win over the past couple of years is even the little bit of investment that the state has given us to try to help start to make a difference in that world, right? And then using the technologies that we just discussed to facilitate working with that world, right? Using the EMR better, using the patient portal better, using telehealth better. So I think, again, we're just in the infancy of that. We've just touched our toe in the water. But I think really to move the Berkshires, we really have to figure out how to take some of these healthcare discrepancies that are out there and normalize healthcare. We're taking care of all the people that are here, and many of them have these socioeconomic situations that healthcare is not top on their priority list. I got to get food, I got to make transportation, all those things that are impeding getting good healthcare.
Can I bring up two quick things? One is I think we shouldn't sell the Berkshire short. We've got a good infrastructure and done some very good things. And one thing I've been telling friends about across the country is because with the whole issue around social justice and with law enforcement, I'm not sure how many people recognize the relationship a lot of law enforcement agencies in the Berkshires have. I believe it's primarily with a Breen Center, where when there's a mental health problem for somebody in the community and the police are called or an ambulance is called, they've got a very tight connection with a community mental health worker of some kind who shows up with the police or sometimes ahead of the police to try and diffuse and de-escalate those situations. I mean, there was just a thing in Philadelphia that happened. So I think we've got that as a well-established, and from what I understand,
Amen.
well
Yep.
system. I was investigating as I was getting ready to move up here last year what was going on. And the other big need I heard is the shortage of clinicians in some areas of the Berkshires. I think telemedicine, I know Bob didn't want me to talk a lot about it, can actually help with the recruitment of clinicians. And then there's another thing called teleconsultation called Project Echo. It started out of New Mexico, but it's gotten a lot of funding. It can help clinicians feel like they're not moving to an isolated area where they're not going to get the support they need. And I think that the implementation and the utilization of that can help with recruitment of more clinicians in the area. The combination of their ability to use telemedicine and teleconsultation to experts around the country may help with improving the regional healthcare system and capabilities.
Bob, I think that we have some technologies in our hands that we don't use completely yet. And so, my idea of, how I think about technology is I just want it to make things easier for me. Just make things easier. And, it's like buying your cell phone. You first learn how to make a phone call, and then you learn about all the other cool things it can do for you afterwards. But what I mean by making it easier is there are a lot of functions, I'll go back to the EHR, that are available that we don't use that could make life easier for our patients. The communications, the relationship management, scheduling, people use it to a various extent, probably not to the fullest. And so I think there are a lot of things we could do with existing technology if we were using it to its full potential that would make life a lot easier for folks. But we're still trying to make it kind of, in some cases, rudimentarily useful. And it's not quite there yet.
Great point, Chris.
And just to add to that a bit, one of the things that I've been talking to a few different community leaders, and a little bit more about my background. I'm on the select board for the small town of Dalton. But in the age-friendly Berkshires, what services do we provide as a community, just for community benefit? It doesn't matter where the dollars flow. And
Right.
Call it remote patient monitoring, call it observation at home, call it keeping people in their homes and as healthy and as safe as possible. And leverage a network and operational framework to deliver that across Berkshire County would be tremendous.
That would be great.
But where do the dollars flow? I think it's an opportunity that we don't care. It could just be done and figured it out, because we will reduce the cost. To Bill's point about the ACO, tremendous opportunity to reduce cost of care.
Right.
But how do you make that investment to go forward in that? Because what we've seen in COVID is that's what the anxiety level and mental health issues that are increasing because of COVID and concerns is just tremendous. So how do you develop a new support model at the end of the day?
Well, Joe, you bring up a really good point. I mean, we should have a robust discussion about what of this stuff belongs as the common good in a community, almost as a utility, right? That would be a really good discussion.
That's great. I'm not sure I want to go here since we're almost at the top of the hour, but it's hard in this energized environment, shall I say, to not pose a quick round the horn question about You know what's coming. Well, let me make it easy. Medicare for all, and the probability that we'll be seeing that, or some derivative of a national healthcare system, you know, in the near future. And then that'll be our last question for the day.
All right, I'll do it.
Go for it, Chris.
Yeah, because Bill might take a step back.
Yeah,
and
I mean, let's be clear. There's, you know, there will never be, right, a quote unquote single payer in the United States, right? There will always be folks who can afford whatever healthcare they want, and they'll buy it from wherever for whatever cost that they want. So there will always be another tier, right? Politically speaking, it's going to be a really hard push. You know, there are lots of opponents, right, from all over the place. But it would relieve a lot of headaches for a lot of people. We look at other systems around the world. A lot of times we point to places like Canada and Europe. Maybe we want to towards Asia a little bit. There's a couple of healthcare systems over there that really work pretty well, and might know some of them through his policy work. You know, from a personal standpoint, I would love it. Some of my physician colleagues would say, "Are you crazy?" Not really. I signed up to take care of people, and it's probably one of the better ways we can do that. The other thing I will say, and this is a lightning rod, right? People don't want socialized medicine. You have it. Okay? We move money around the system behind the scenes now. That creates more of that kind of system than a single payer system would create. Just so you know.
Bob, I've worked in policy and worked on Medicare going back about 30 years, from the White House to Congress to other places. And getting back to my circles, Medicare for All only talks about financing. It doesn't talk about delivery. I would urge people to go read Atul Gawand's article, because he talks about how those systems that Chris mentioned are really not just uniform national health systems like we think they are. Canada's actually a provincial system, and how they got there is a whole thing. And for anybody who thinks Medicare is the greatest system, it's not. It's got its problems, even as a payer, because Medicare doesn't deliver care, it just pays for care. It's really complicated, it's really bureaucratic, it's become quite politicized, and it's got a number of very significant challenges in how it operates. And just so you know, the bills that have been introduced called Medicare for All are not taking the current Medicare system and expanding it to everybody. They're dramatically changing the existing Medicare program, because Medicare doesn't pay for a lot of things already. And, you know, I think I'm going to lay my cards on the table. The Affordable Care Act, as I foreshadowed a little bit, made a lot of really good improvements. It created sort of the ACOs that Bill talked about, which really were changing the incentives for healthcare providers, system, you know, healthcare delivery system clinicians, from just doing more stuff to actually creating better health for people, better outcomes, clinically as well as economically. We've seen changes to the ACO over the last 4 years. It wasn't perfect to begin with. It's changed significantly, and I think it's going to change significantly going forward. And the question is what direction it changes. There's a court case before the Supreme Court now, and you know, the second Trump term or a Biden presidency, I think would change it in dramatic ways as well. I think it's Medicare for All or single payer is a political term. It's a catchphrase that doesn't have a lot of substantive meaning. It's good politics, it's bad policy. And I've said that before, and I just said it again.
So I'll just put my own 2 cents worth in. It was said by Chris and Mike, so I'll just reinforce that Medicare for All is insurance reform. It's not care reform. That's really what it's aiming at. And we do need insurance reform. Exactly how that's done, what form that takes, is sort of interesting, and we'll find out about it. You know, I'm concerned that one of we have in this country the best rescue care system in the world, but we also have not so good numbers when it looks at quality and outcome data compared to the rest of the world. And much of that is simply because we spend a lot of money on care, and we spend not so much money on preventing illness or making people healthy, or, you know, what they used to use in the old cowboy movies, head them off at the pass.
Well,
You know, make sure that you don't get diabetes, so we don't have to pay for that. That you eliminate through the environment and your food known causes of cancer that we breathe, ingest, and eat, and maybe you lower your cancer rates in certain areas. How do we not get out of the rut we're in, where we're spending? Mike alluded to that in his presentation. You know, almost twice as much per capita on healthcare that the rest of the world spends.
Actually, Gordon, I got to jump in because
Mike, let me just mention to the participants, we're a little over our 3 o'clock time, and this is such a great discussion. Let's keep it going, and for another maybe 5 or 6 minutes, and then we'll have a hard stop. So back over to you, Mike. Sorry.
I'll put some more quarters in the meter. Is that when you look at international comparisons, and Elizabeth Bradley, who's now the president of Osher, she was at Yale, did some great research on this. If you look at the international comparisons, we spend twice as much per person on healthcare, but we spend a lot less on social services. And those social services do things like not just make sure people get better food, but make sure somebody who's got diabetes, they actually get their medicine and they take their medicine and they can get to their appointments and all sorts of things. I don't have the chart in my slides, maybe I should have put there, but if you stack what we spend on healthcare and then you put social services on top of that as a percentage of GDP or as actual dollars, the US comes about right out in the middle of all the major OECD countries.
We just call it something different.
Well, I'm sorry, what do you mean?
We just call it something different. The money is called healthcare, but a lot of it is really social service.
Well, no, but what we do, we don't spend it on social services. We spend it on healthcare. We spend it, no offense to you guys in the panel, we spend it on doctors and hospitals instead of on the social services, social workers, community health workers, making sure people have good housing, good transportation, jobs. Some of it's the environment. It's a pretty dramatic difference. Mm-hmm. Basically, most other countries spend $2 for every dollar, $2 in social services for every dollar they spend on healthcare. In the US, we spend $2 on healthcare for every dollar we spend on social services. Complete ratio inversion.
Yep.
And so you've got to, again, it's that looking at that. I like that chart I use with the 5 circles and the community. You got to look at the holistic thing, because that's really what gets you to the health of the population. I think Joe mentioned before, there's what causes health. Healthcare is maybe 20%. The other 40, there's like 30% on the environment, 30% on personal behaviors, 20% on genetics. So if you really want to improve people's health, you got to look at all those different factors. And unfortunately, the reality is that the healthcare we provide is not the major proportion. That's just the reality. I'm glad Chris is shaking his head in agreement.
Totally agree.
Bob and Gordon, one of the things, when I think about Medicare for all, I stumbled into the healthcare career many years ago. But I also had a personal experience with my baby girl who ended up being in a NICU for 92 days. Thank goodness I had health insurance, but I met a dad who did not. And for no reason, the same situation. So how do we make sure my neighbors, the community members, people that, around us get what they need, and we have a reasonable way to fund it or do things. But God forbid, it was, I saw that EOB and I just choked. I'm like, thank goodness. So.
I will say Massachusetts has done all the right things in the environment. And I'll confess something here. Are we still recording this, Andy? Fine. It's one of the reasons I moved here from the DC area when I was looking to leave the DC area, because I knew that if the Affordable Care Act went down the tubes, Massachusetts would still have a good health insurance system. I lived here when Romney Care went into place. I moved to DC before the Affordable Care Act and got denied insurance. It's just, so I think you're exactly right, Joe, as to how we construct a system, whether we call it the Affordable Care Act, Obamacare, Biden care, Trump care, somebody's got to care. But if there isn't everybody in the system and people are left hanging, I mean, your situation is similar to, I think, what Jimmy Fallon's been talking about with his kid.
Mhm.
He had the
Yeah.
money and the insurance, but he knows that people who didn't, it's catastrophic.
You know, Mike, you started this off by talking about how complex it was, and we talked about complexity of data, complexity of interoperability. So I'm great that there's a lot of minds on this panel listening in, or the audience, to help us all solve these problems at the end of the day.
Yeah.
Well, it was the old saying, if it was easy, somebody would have fixed it already.
Right.
Bill, do you have any final comments?
You know, I think, and thank you, Mike, we have done some great things with healthcare here in the Berkshires. You know, I feel proud to be part of it. I think watching the chat, we've got a long way to go. We've got a lot more to do. And whatever we call this next version, Medicare for all, we have an opportunity. You know, we have an opportunity to do some good things, to kind of change how we deliver care, to make sure it's a much more holistic care model, to take advantage of all this technology that can help it. Amen. So I'm looking forward to helping continue to make it a better Berkshires, to make healthcare better. And thank you for letting me be part of this.
Bill, that's just a perfect way to tie a bow around a rich and engaging session. So thank you to all of the panelists. Thank you to all the participants. This has been great. Just a quick reminder that we have our 7th class next Thursday, same time, same channel. It will be on the societal impact of technologies that we've been discussing. So I think a lot of the themes that we've picked up here today and have been in the last several classes, social equity, access to technologies, cost structure around the procurement and application of technologies will be discussed. So it's going to be a fascinating discussion about the positive future implications of technology on society in this region, as well as some unintended consequences. So until next Thursday, thank you all.
Thank you.